Good afternoon, everyone, and welcome to session 4 of the American Liver Foundation's Liver Health Echo Program Cohort 2. Today's focus is interdisciplinary models for MASLD management as well as a program overview. We're thrilled to have you to join us today. I'd like to begin with a warm welcome to all of our participants. We're excited to kick off this session and we look forward to your engagement. Please state your name and the organizations you represent in the chat. We're honored to have two distinguished speakers with us today. Please join me in welcoming our overview presenter, Dr. Alejandra Meza. Originally from Peru, Dr. Alejandra Meza completed her medical degree in her home country before relocating to the United States to pursue advanced training. She completed her medical residency at Yale, where she cultivated a strong foundation in internal medicine and developed a deep interest in liver health. Dr. Meza is now preparing to pursue a fellowship in gastroenterology and hepatology, with a particular passion for metabolic dysfunction associated steatotic liver disease, MASLD. Her clinical focus and research interests center on improving outcomes for patients with liver disease through evidence-based care and innovation. I would also like to introduce our case study presenter, Dr. Jennifer Asotibe. Dr. Jennifer Asotibe is currently a gastroenterology fellow at Montefiore / Albert Einstein College of Medicine in New York. She earned her medical degree from Windsor University School of Medicine in St. Kitts, followed by an internal medical residency at John H. Stroger Junior Hospital of Cook County. She then completed a transplant hepatology fellowship at Rutgers, New Jersey Medical School, where she deepened her expertise in liver disease and transplant care. Outside of medicine, Dr. Asotibe enjoys staying active through workouts, discovering new restaurants, and traveling to explore diverse cultures and cuisines. Um, Dr. Meza and Dr. Asotibe, if you guys want to take over this with your slides, that would be awesome.
Thanks, Isabella, for that introduction. Hello, everyone. Thank you so much for having us. I'm going to go ahead and share our slides. I hope it works just fine. Okay. Are you guys able to tell me if you can see the presentation? Yes. Okay. Amazing. So, we can kick things off just by stating the topic for today. So it's interdisciplinary care models for the management of MASLD. So as I know that the prior excellent sessions have already covered what MASLD is, right? So it's a liver disease and it's mainly driven by all of these metabolic disorders that we're going to go through throughout the presentation. But why is MASLD such a problem, right? So why is it becoming such a hot topic lately? And one of the reasons is this increasingly growing prevalence. We can see here well, number one, that in North America or the US, we have one of the highest prevalence if we compare it to other countries worldwide. And also we can see that if we look back to prior years, so let's say 1990, the global prevalence was around 17%, then growing exponentially in 2019 to around 20%. And now, just last year, it had almost doubled this number to up to 40 to 50%. There's also been a bunch of studies that have been published in prior years, and they kind of throw some numbers of what the prognosticated prevalence would be around this time, and we can see that the numbers that we're actually seeing right now have surpassed all of those prognostications. So that is actually very alarming. And another big reason as to why this is such a problem is that we will see how this liver disease is not only a liver disease, but it's also like very closely related to these metabolic diseases, such as this diagram very nicely outlines. So people with MASLD have actually also a very high prevalence of diseases such as high cholesterol, high triglycerides, hypertension, diabetes, and we all know that these diseases carry a very high cardiovascular risk in the future, which is actually the number one cause of mortality in these patients. So we can see how this like very hugely impacts this population. So having said this, so like specifically having said that this liver disease is not only a liver disease, but it also kind of like entails these other metabolic diseases as well. That raises the question, is it appropriate to just address these people with MASLD under one perspective? So let's say the PCP or just a hepatologist or just a gastroenterologist, or does it make more sense to get more people involved, get more subspecialties involved in order to give these patients a more like thorough or holistic care? So this is essentially what the multidisciplinary care model suggests, right? So all over the world, we see that this is slowly being more and more implemented. And we will see, as we will explain later, that in between these countries, they usually serve the same like baseline pillars. However, there are more specialties that have been suggested to be part of this group of multidisciplinary care. So just to mention a few of them, primary care physicians, cardiologists, hepatologists, endocrinologists, but also psychologists, internal medicine specialties, obesity specialties, nutrition, some others suggest even exercise physiologists. So we can see how a lot of different groups can jump in to kind of complete this care. However, are all these specialties necessary, and like what is currently being implemented? So like I said, there have been a lot of proposed approaches, but most of them have some pillars in common. So just to give you guys an example, this is taken from the 2023 guidelines of the AASLD for the management of MASLD. And we can see three main pillars, right? So number one, we see the primary care provider or endocrinology, which we will talk more thoroughly about, but essentially these guys will serve as our first step, like our triaging part. Then we see another huge pillar that is nutrition and lifestyle interventions, because this is going to be one of the cornerstones of the management of people with MASLD. And then we, of course, have our gastroenterologists and hepatologists, who will be in charge to manage the like more of an advanced disease patients that come across. And then we see these other branches, right? We have the cardiology, since like diabetes, hypertension, or increased cholesterol, these can all be managed by cardiologists as well. Then we have the weight management and health psychology, which we will also talk about later. But how do we get all of these teams involved? Like who's gonna call who? When is it appropriate for me to call someone else? And we can go like to the beginning. It all starts in the primary care setting. So that's why the PCPs have such a big role in this management. So the PCP will essentially get a new patient. They will see their clinical risk factors or any risk factors identified during the physical exam or in the vitals or the weight. So let's say I identify my patient and he has a very high BMI, so he has obesity or he is overweight. And then when I go through his chart, I see that he also has diabetes, let's say. So these are just like some red flags that will tell me, okay, this person might benefit from me taking more lab tests, right? So such as a CBC, a CMP, check their liver function test, check the lipid profile, etc. So with these very simple blood tests, the primary care physician can do something that is called the FIB-4 score, which is essentially using the platelets, the patient's age, and the ALT and AST. These can all go into a calculator. We could use MedCalc sometimes, and it will throw out a number. So this is what we will use as a starting point to see, does this patient need further follow-up, or is it okay for me to just monitor him? So what we see here is that if the FIB-4 score is less than 1.3, then this patient can just be followed up either every 1 to 2 years or either 2 to 3 years in the primary care setting. However, if it's equal than 1.3 or higher, that's where I have to start thinking about further screening and further follow-up. So more than 1.3, but still less than 2.67, as we see in the right side of this diagram. I can think about doing a secondary assessment, which can involve either imaging. So this is the VCTE or elastography, which is a type of ultrasound, like kind of an ultrasound that will measure liver stiffness and degree of fibrosis, or an ELF score, which is also a blood test that measures up to 3 serum biomarkers that will tell us about the degree of fibrosis. So this will also help me determine how severe the degree of fibrosis or stenosis that my patient has. However, if the FIB-4 score is already even higher than 2.67, then is when I think, okay, I really do need to refer my patient to a GI or a hepatologist, and they will be in charge of carrying the remaining workup in terms of, does this patient need a liver biopsy? If he does, what are the next steps? Like how severe the disease is right now in order to take the appropriate interventions. So just to really emphasize here, as one of the subspecialties that I mentioned before, that we're part of this multidisciplinary care model, and this is like something I really want you guys to take away from this presentation, is like the big role of the primary care physician. Like they will be in charge of actually being able to promptly and like identify a patient at risk at a very early stage that will allow us to take prompt interventions to avoid this person to be diagnosed in a very later stage in the disease. And this is kind of what we already talked about, right? So we will identify if the patient has risk factors. We will do some blood workup that will serve us to take the FIB-4 score and determine where should my patient go from then. So what about the other subspecialties, right? So one of the biggest ones will be cardiology. We already said that liver disease, this kind of liver disease is very closely related to other metabolic diseases such as hypertension, such as diabetes. So why is this so important? Is that this cardiovascular risk is actually the leading cause of mortality in the patients with MASLD, and up to 50% of them have concurrent CVD already. We also just mentioned the FIB-4 score, right? In terms of it being used to triage these patients. However, a high FIB-4 score has also been correlated to a higher severity of coronary artery disease and calcium coronary scores in these patients as well. It is still unclear, and it's still a matter of studies. It's still a matter of ongoing studies to determine whether a high FIB-4 score should already prompt the cardiologist to say, okay, this patient should have a more advanced coronary study to see if they will develop if they are at risk to develop an MI, for example. Because let's remember, these studies are also costly and can sometimes be risky for the patient. So in terms of risks and benefits, it has not yet been clearly elucidated, as to, do I need to refer my patient to further studies or not? However, this is something that should raise concern if my patient's FIB-4 score is very high. Then in a patient by patient case basis, analyzing their other risk factors and whatnot, we can think about further studies for their coronary health as well. Then we, of course, have the hepatologists, which I briefly mentioned. They will be in charge of already monitoring the disease progression, management of already advanced stages of the disease, and of course also preventing and treating the complications of liver cirrhosis in this case. And we then have the endocrinologists, and this specialty has a two-parter in terms of how they can be involved. One of them is obviously managing very complicated cases of things such as diabetes or obesity, sometimes in the primary care setting, we're not able to meet all the like requirements or have all the tools appropriate to manage these difficult cases. However, the endocrinologists already have such a like a subspecialized knowledge about these metabolic diseases and about these endocrinology diseases that they can also very quickly identify people that would be at risk for MASLD. So in this case, they could also help the primary care physician identifying these patients earlier and referring them to appropriate care before this disease progresses. So let's go back to this diagram again, just to emphasize once again that these metabolic diseases have a high prevalence in these patients. And the reason as to why this is important is because of this cardiovascular risk and how this can affect their mortality. So what do all of these diseases have in common in terms of like hypertension, diabetes, high cholesterol, etc., is that for their management, they will rely very much on lifestyle modifications. So this is what we're going to talk about next, which was also, if you guys remember, one of the pillars suggested by one of the first diagrams. So we already talked about the PCP. Now we're moving on to the lifestyle intervention parts. So just start by saying that all of this is has the goal of weight loss, so weight reduction. We will see how this very hugely impacts all of this, not only MASLD itself, but also all the other diseases that it's related to. So on one hand, we have nutrition. Of course, excess calories will signify an increase in weight. But sometimes it's not only just about the calories, but also the type of food that we eat. So food that is high in saturated fats, refined carbohydrates, or beverages that are sugar sweetened have been closely associated with increased obesity and MASLD. Also, excess fructose has been associated with increased MASLD, even MASH, and advanced fibrosis, independent on how many calories we're eating. So what is being suggested in terms of like what interventions we can take in the nutritional aspect, one of them is the diet, right? So it will all revolve around a caloric deficit that would allow us to drop weight. Is there any specific diet that we should follow? Well, the one that has been mostly studied and that has shown more promise is the Mediterranean diet, since it's shown that it improves cardiovascular health. However, it's not necessary to follow this specific diet. As I said, one of the main things will be to be in this caloric deficit. Also, coffee consumption, like either with or without caffeine, has been shown to improve, will have positive effects on MASLD. And of course, avoiding excessive alcohol use will also benefit these patients. Then on the other hand, we have exercise. And exercise, even like independent on the fact that we're losing weight or not, has been shown to have like both hepatic and cardiometabolic benefit. So this will always be recommended to our patients. And as we know about this has been already stated in several guidelines, the recommendation of exercise of moderate exercise, sorry, at least 5 times weekly or for 150 minutes total. However, we know that sometimes, I mean, this might all be might all sound easy, like, okay, I'm gonna eat well and I'm gonna exercise, but it's actually very hard to execute. And of course, every patient will be different. Every patient will have a lot of things to do during the day. We actually find that like changing one's lifestyle is one of the hardest interventions for our patients to carry. So having said that, maybe it's very hard for me to tell my patient, okay, do 150 minutes of exercise each week. That will make you better. Instead, we could like make small goals, right? So increase your activity level by at least 1 hour weekly. And that has also shown to have a lot of benefit in these patients as well. So sometimes what I do in my practice is like divide this like an hour weekly and tell them, okay, let's start by you walking half an hour 2 or 3 days a week. Like, do you think you have like half an hour to spare? And most of the times the answer is yes. Because if we think about it, like we put half an hour in perspective of a whole day, and it really sounds like something doable. And I think it's a great starting point to at least get our patients to get into this habit of exercising. So like we said, the goal of all of these interventions essentially is to lose weight. And actually there are like clear even numbers suggesting how much weight we should lose and correlating them to what the effect would be. So at least 5% weight loss has shown to reduce total liver fat. Then if we move on to 7 to 10% weight loss, that decreases liver inflammation, and then 10% of weight loss or more has actually shown to improve fibrosis. So as I was saying, the other drugs that are being studied are coincidentally also drugs that are used to treat these other metabolic diseases, right? So for example, for cholesterol, statins, ezetimibe are being studied. For hypertension, ACE inhibitors, ARBs, or calcium channel blockers are being studied. For diabetes, metformin, it's also being studied. So most of these drugs have found, or most of these studies have found that yes, these drugs might benefit MASLD, though indirectly, just by improving these other metabolic diseases. Um, However, they have not been successful at proving like a histologic change in the liver just yet. So that's why they have not been approved for the treatment of MASLD itself. And besides pharmacologic therapy, we of course have bariatric surgery, which is, as we can see, a much more invasive intervention. But who is eligible for this surgery? So patients with a BMI of 35 or more. This is irrespective of other metabolic comorbidities, or a patient with a BMI of 30 or greater plus some comorbidities, which are diabetes, hypertension. And before MASLD or MASH was not considered one of these metabolic diseases, but we see that this is now like increasingly being qualifying as a comorbidity in order to get our patients this bariatric surgery referral. Why is this so impactful? It's actually shown to resolve MASH, improve hepatic fibrosis, and obviously induce the sustained weight loss of up to 30%. And overall, it also decreases all-cause morbidity and mortality in these patients. There have been many studies. Some of them are longitudinal prospective studies that have shown a resolution of MASH without worsening of fibrosis in up to 80% of patients just a year after the surgery. And there are also some studies suggesting that the sooner we get the patients this surgery, of course, if they meet the indications for it, they would see faster results in the resolution of liver steatosis and fibrosis. And then last but not least important, the role of psychologists, right? So we all know that for patients, let's say with obesity, with diabetes, they carry a lot of stigma in our society, and that like one can think that this is definitely something we should address by a psychologist. For MASLD itself, however, there's still some more studies to like clearly elucidate the direction of how one affects the other. So, for example, is it the psychiatric diseases, the ones that are negatively impacting the management of MASLD, or is the fact that my patient have MASLD affecting the psychiatric comorbidity? That's still a little unclear. But data shows that, I mean, there is some association. There are also conflicting data as to whether a psychological intervention will like significantly improve the outcomes of MASLD. And also other studies have failed to find associations in between MASLD and psychology. So all in all, I think there is still like work to be done in terms of like fully determining the association between these. However, we see that in multiple care models, not only here in the US, but also in Canadian care models, and in other countries in the world, psychology is a big part of this management. So I think it really makes sense, and it's really reasonable to include this subspecialty for the management of these patients. Um, as we saw in the third session of this ECHO program, we learned that the socioeconomical status is something that can hugely impact the care of these patients and their access to healthcare. So I think that the role of the psychologist is very important for these patients as well. So like having such a big group and including so many subspecialties sounds like it's gonna work. It's a perfect way to manage our patients, give them all the like holistic approaches that they need. However, what are the barriers, right? Like like getting so many people involved certainly raises some consideration as to, for example, the location. Like, am I gonna have all these subspecialties in one single building or not? Like, is that viable or not? Then coordination or and communication in between all these subspecialties. They have to know if I, as a PCP, say something to my patient, they should also be aware of my plan. I should also be aware of what the recommendations are, and that can also be sometimes a little difficult. Then also, of course, resources, not only from like the facility or institution itself, but also the patient resources. Like, is my patient going to afford being seen by so many subspecialties? And then is the institution gonna like be able to afford to have all of these subspecialties involved in the care? Then obviously there's time, since we see so many people involved. Like, is our patient gonna attend all these different consults? That's an hour consult plus the commuting. And obviously this also raises concern for costs, right? And again, not only for the institution, but also for the patients. If my patient is going to have to move from one place to the other to get all of these to get all of this care, like, is cost of transportation going to be an issue or not? Things like that. I think it's very important to consider as well. I think that now we are getting like more savvy in technology, so that could be a very like important tool to use, uh, like for the matter of getting all of these subspecialties together. However, I think there's still some work to be done in terms of coordinating in the most like efficacious way. Um, for these patients, like, right, like all of these subspecialties, sorry. So just some key takeaway points that I wanted to mention. Like I said, I really wanted you guys to stick with the fact that the primary care providers have a very crucial role in the screening of at-risk patients. Um, this will signify grabbing a patient early, like on an early stage in the disease, or even not having the disease at all, and I can like get the ball running in terms of lifestyle interventions, like even before they need medications, even before they need surgery. Then the use of FIB-4 score, a simple blood test, is very key to make these prompt referrals and ensuring a safe surveillance on the primary care setting. Then the lifestyle changes aimed at weight loss that are one of the cornerstone in the management of MASLD. The fact that there is a high and increasing prevalence in cardiometabolic risk in MASLD patients. Let's remember that like the cardiovascular outcomes, like the cardiovascular aspect, is the number one cause of mortality in these patients, and that up to 50% right now of patients with MASLD have concomitant cardiovascular diseases. Um, then number 4, that the obesity pharmacotherapy and bariatric surgery are both very effective interventions, but only in eligible patients with MASLD. Let's remember that these, like any pharmacological therapy, will have their side effects and increased costs, and obviously bariatric surgery, by it being a surgery itself, not only the cost, but also all the burden of the procedure and post-procedural complications that could happen, right? And last but not least, that although psychologists are being part of this proposed multidisciplinary care models worldwide, there's still need for further studies to determine the association between mental health conditions and MASLD. So now let's move on to the cases. I think Jennifer, you can take it away.
Okay. Dr. Meza would just help me move on the slides, but yeah, thank you guys once again for having me. And I have 3 cases today that I'm going to review and try to tie into what she talked about earlier in the session. So let's go back to just the slide prior. Just with this case, these 3 cases that I have, I just wanted to put down the learning objectives. So we're going to briefly review some risk factors and non-invasive assessment of fibrosis and MASLD, then review an interdisciplinary management with specialists like hepatology, nutrition, cardiology, like she mentioned, especially in patients that are high risk. And then I also wanted to highlight practical steps in this patients, the outcome, goals, and the monitoring. And then finally, discuss, shared decision making, patient education, and long-term follow-up. So our first case is Mr. IS. He's a 33-year-old man and was found to have elevated liver tests. He does have a past medical history of hypertension, hyperlipidemia, and diabetes. Has never had any surgeries before. For his social history, he denies any smoking, any drinking, or illicit drug use, doesn't use any over-the-counter supplements, and he says he plays soccer and takes evening walks. His father has a history of cirrhosis, but was unable to tell us the etiology of the cirrhosis and was diagnosed many years ago. And for his vital signs, his BMI was 30, which we can classify as class 1 obesity. Blood pressure was stable, his heart rate was fine, and his temperature was fine. For his labs, he does have an ALT of 87 and AST of 50, which you tend to see in patients with MASLD. A lot of times we see a lot of ALT predominance in MASLD. A month prior to when he saw us in the hepatology clinic, his ALT was even much higher. It was 124 at that time, and his AST was 44. His T-bill was normal. Alkaline phosphatase was borderline elevated. A1C was high, 8.2%, and his cholesterol was also high at 232. We can also see that his LDL was 147, triglycerides were 234, and HDL was 39. For his medications, he came in on lisinopril. He was already taking Synjardy, famotidine, sildenafil, and melatonin, and he had no known drug allergies. So what are the next steps? So for workup, he got a hepatitis panel, which we always want to rule out in patients that have MASLD. So we checked the hepatitis panel, and he was Hep A immune as well as Hep B immune, and his Hep C was negative. You also want to rule out any autoimmune causes in this patient, and especially in this patient that was young, coming in with elevated tests. So we did IgG, IgM, and IgA, which came back as normal. We probably did an overkill in our clinic by checking the ceruloplasmin, but we checked the ceruloplasmin, it was negative, and we wanted to just rule out hemochromatosis. His ferritin was 256, and his TSAT was 31%, so didn't meet the criteria. For ultrasound, we checked an ultrasound, and it showed mild hepatomegaly, and he had a diffusely echogenic liver. And I thought this was interesting, but his FIB-4 score when he came in was low, 0.84. So if we were going by the FIB-4 score, this patient might not have met the criteria for further workup. But this made me actually go, look at the guidelines on, or like the utility of the FIB-4 score. And there was an article that came out in ASLD a couple years ago about like how sensitive the FIB-4 score is. So in certain patients, especially patients that are less than 40 years old, is not very sensitive. The sensitivity is around 70%, while like the negative predictive value is around 95%. But if a patient is less than 40 years old, maybe we should not be fully relying on this FIB-4 score, especially if you have like a high clinical gestalt that you're suspecting MASLD. So in our patient's case, he already had hepatomegaly on ultrasound and a diffuse echogenic liver, didn't have any alcohol use. Our FIB-4 score didn't exactly correlate, but we went ahead and we got an ultrasound elastography because we were suspecting MASLD, also given the fact that he had those like comorbidities. So the ultrasound showed an F2 to F3 score, which had a kPa value of 10.7, and this was interpreted as F2 to F3 fibrosis. So this slide, I just wanted to briefly, again, review like the pathogenesis and add on to what Dr. Meza had already talked about of MASLD and why it's really important that we have like this interdisciplinary management. So with MASLD, a lot of patients develop dysbiosis in their gut, especially from a pro-inflammatory diet. You can see that a lot of these patients have insulin resistance, especially if they're diabetic. So with the insulin resistance, you have increased free fatty acids influxing into the liver, and that's how you develop fat or steatosis in the liver. From that, you develop what we call lipotoxicity, and then you get oxidative stress, you get inflammation. Eventually, you develop fibrosis when you have activation of stellate cells. And the inflammation that causes MASLD, it usually happens throughout the entire body and increases your risks of like developing strokes. You can have patients can have heart failure, you can have arrhythmias, you can even have cancers like colorectal cancer, stomach cancers, and chronic kidney disease. So all of this inflammation have shared mechanisms. And so that's why it's really important that interdisciplinary management should be implemented in these patients. So let's go back to this patient. What are his risk factors? He's diabetic, he does have hyperlipidemia, and he has hypertension. So already has at least 3 metabolic risk factors, and then he has a BMI of 30, which is class 1 obesity. The good thing is that this patient doesn't have any alcohol use, and we did ultrasound elastography, and he has moderate fibrosis. So this slide was just to briefly for us to look at his Medeville score and see exactly where he stands. So when you have F0 to F1 fibrosis, it means like you have absent or mild fibrosis. When you're F2, you have significant fibrosis, and F3 is what puts you at severe fibrosis. Our patient had a kPa score of 10, greater than 10, so he was between like F2 to F3. So he was intermediate to advanced fibrosis. So what is the role of the interdisciplinary team in this patient? So again, like Dr. Meza had mentioned, the primary care physicians play a big role in this patient because they see the patient first. So for this patient, they would help manage his comorbidities. And in our case, he was the primary cares were heralding the management of his hypertension, his hyperlipidemia, and diabetes. The primary care physician would also be the one performing the non-invasive fibrosis screening, like getting a FIB-4 score. And if it's, more than 2.67, like she talked about, you need to see a hepatologist, get referred. Or if they're between that range of 1.3 to 2.67, they can, go ahead and get extra testing, like, a transient elastography or an ultrasound elastography. And if that shows F2 or F3 fibrosis, then they should be seeing a hepatologist. The primary care should also be screening for ASCVD, because remember we mentioned that this patient, at least 50% of patients that have MASLD might have concurrent cardiovascular disease at the same time. So, they can always like screen for ASCVD whenever they see these patients. And they also play a role of referring the patients to the hepatologist. So when they come to us, what do? Our role is to, stage the fibrosis, know exactly what the patient is on the fibrosis staging, and make sure that we don't allow the fibrosis to progress. Like, try to mitigate the risk factors that's putting them at risk of fibrosis progression. And obviously, if our patient develops cirrhosis, we need to do surveillance imaging in these patients. And if they develop decompensated cirrhosis, then we need to consider referring to a transplant hepatologist if we don't have that expertise. Also, the hepatologist plays a role of like, trying to prescribe specific therapies, MASLD therapies with the assistance of other specialties. So in this case, we did have the hepatologist following this patient, and we were following for like staging the fibrosis. And then a cardiologist, in this case, guidelines recommend, the AHA recommends that patients that have an ASCVD risk that's intermediate to high, so greater than 7.5% to less than 20% 10-year ASCVD risk, should be seeing a cardiologist. And that's why I recommend that the PCP should be the ones doing the ASCVD risks whenever they see the patient. We can also help with that, but the PCP should play that role. And if we find that the risk is high, then we should have this patient see the cardiologist early in time, then wait until they develop significant cardiac disease. I wanted to know if, given the fact that we had 50% patients that have MASLD have a 50% chance of having concurrent cardiovascular disease, we should be recommending aspirin in these patients. But there's no like any large studies that recommend aspirin for prevention of cardiovascular disease. Then for this case, we should also have an endocrinologist following, because the patient has really bad diabetes. So the endocrinologist is to help manage the diabetes better. And we have medications, like she mentioned, this metformin. We have GLP-1 agonists. So definitely needs to play a role in this case. And then the nutritionist has to also follow in this case, because they will the ones that are going to help with dietary counseling and weight loss strategies. So like she mentioned, the Mediterranean diet has been studied in these patients with MASLD. Our patient was actually placed on a DASH diet as well, but that's because the blood pressure was not well controlled. So they put them on DASH diets. And some studies have also shown that sometimes DASH diets can help in patients with MASLD, but the preferred diet is Mediterranean. And for our case, we recommended like a goal 7 to 10% weight loss because his BMI was 30. Next specialty that should be on this case would be like an exercise physiologist. And I put question mark nutritionist because I know some centers might not have an exercise physiologist. At least I know in my practice, we don't have that. And the nutritionist sometimes plays that role, like, gives the recommendation about the exercise of 150 minutes per week of moderate activity or 75 minutes per week of like rigorous activity. Then definitely need to have a behavioral health to see this patient, just to assist with a motivational interviewing. Like Dr. Meza mentioned, it's easy to like give all these recommendations, but it's hard for a patient to actually institute all these changes, So definitely a behavioral health will help with like support, rapid adherence support, and motivational interviewing. And then finally, in this case, I would also consider a bariatric referral because their BMI is above 30 and they have 2 cardiometabolic risk factors. Now, it doesn't mean that the surgeons will go ahead and, push for surgery immediately because his BMI is like borderline, but I'll just have them see the patient at time. So what are the management goals in our patient? Short-term goals is 3 to 6 months. So our goal would be to see if they can lose a weight of 7 to 10% within those 6 months. You also want to optimize glycemic control, manage the blood pressure and lipids, and try to improve the liver enzymes. And then you also want to make sure the patient can maintain their exercise routine. And then long-term goals, obviously, for this patient with management of the MASLD would be to reduce the cardiovascular risk and events, and then prevent progression, to cirrhosis or development of hepatic decompensation, and making sure the patient has lifestyle sustainable change. So what were the medical and pharmacological managements that we instituted in this patient? So I did mention that, for this patient, lifestyle management is foundational. However, pharmacotherapy can be considered given his comorbidities and his stage of fibrosis. So for his diabetes, GLP-1 agonists, like Dr. Meza mentioned, would be good for his management. I should also mention that it was recently approved for MASH. Our patient was actually put on the GLP-1 agonist, and when we saw him a couple months, he did lose a significant amount of weight, and it helped improve his liver enzymes. And then given the fact that he has hyperlipidemia, definitely needs to be on statins. And, we've mentioned that they have been shown to be safe in patients with MASLD given their high cardiovascular risk. And then for his hypertension, like Dr. Meza mentioned, would be ACE and ARBs that we recommend, or even calcium channel blockers. Our patient wasn't a calcium channel blocker, but ACE and ARBs have been shown to reduce cardiovascular disease risk and even improve liver outcomes indirectly. And then for liver-specific therapies like resmetirom, like she mentioned, it's approved, like she mentioned, for F2 and F3 fibrosis. However, the trial, which was the MESTRO-NASH trial that looked at resmetirom, it excluded patients that were on concomitant therapy like GLP-1 agonists or vitamin E. So I guess my question I was asking myself was, this patient with F2, F3 fibrosis, would they be candidates for resmetirom given the fact that they're already on a GLP-1 agonist? And I guess a lot of people, I don't know if you guys experienced that too, but in my practice, it hasn't been easy prescribing this medicine. Actually, I haven't seen it prescribed as of yet. I don't know if some people have had success. But in this case, with this patient that has a BMI of 30, I would definitely start him on a GLP-1, reassess him, see how he does in a couple months with, non-invasive fibrosis testing, like an ultrasound elastography. If he's improving, or his fibrosis is improving, then I don't see the need to put him on a resmetirom. The next slide, I just wanted to briefly talk about the ASLD practice guidelines on the use of resmetirom. So resmetirom is recommended in patients that have evidence of MASLD, and you can use non-invasive liver testing like a FibroScan, which is a transit elastography, or an MRE to make that determination. So if they have a KP of above 8 on transit elastography, that correlates to around F2 to F3 fibrosis, you can start them on this medication. Or patients that get biopsies, if they have a liver histology of F2 to F3 fibrosis, then yes, you should be putting them on this medication. patients that should not be getting this medication are patients that have cirrhosis. So definitely it was excluded in the trial. So we can't say the safety profile in patients with cirrhosis. Patients that also have other causes of liver disease should not be on this medication. And if they have a lot of alcohol use, then guidelines recommend not to use these medications. And then finally, active thyroid disease should not be used on these patients. So when you initiate resmetirom, you definitely want to monitor for safety profile at 3, 6, and 12 months. And you're looking at a hepatic function panel at 3 months. You're looking at a thyroid function panel and like a lipid profile. You measure that at 3, 6, 12 months. If they develop any like related adverse events, you want to stop the medication immediately. At 12 months, you want to reassess. Initially, if you diagnose the MASLD with, let's say, a transient elastography or an ultrasound elastography, you want to repeat that testing again in 12 months and see if they're improving. Also, you check their liver test, see if their ALT is improving. If they have worsening of their fibrosis while on the medication, that means they don't have any response and you want to stop the medication. However, if they have improvement and the improvements mentions more than 25% of their KPA, improvement in their KPA on a transient elastography, or more than 20% on an MRE from baseline. So if they have improvement in their fibrosis, then that's a beneficial response and you want to continue the medication. So for this patient, back to our patient, for him, so for monitoring and follow-up, we repeated liver enzymes every 6 months, and we saw that his numbers were coming down with his weight loss. So 6 months is appropriate in this patient, given just the degree of elevation when we first saw him. And then we can always repeat the fibrosis testing with a transient elastography every 12 months. I would advise in this patient, because we had that discordance in the beginning between the FIB-4 and the transient elastography, that the follow-up test should be a transient elastography, just so it's like concurrent. You're not screening initially with transient elastography and then checking again with the FIB-4. So we'll repeat non-invasive testing with the transient elastography in 12 months. And then just keep an eye on his glycemic control, make sure his like blood sugars are controlled, his A1C comes down, his blood pressure is stable, and his lipids are stable as well. And then also check on like his exercise routine, weight, and diet. Our second case is Miss JJ, and she's a 63-year-old woman, and she was found to have elevated liver tests on a routine workup. Her past medical history, she does have hypertension, hyperlipidemia, prediabetes, and chronic left knee pain. Her mother has a history of fatty liver disease, and she denies any smoking, drinking, or illicit drug use, but she uses an over-the-counter medication, glucosamine, multivitamins that she's been using for many years. Does not exercise. She has no known drug allergies, and she's on amlodipine and famotidine medications. For vital signs, her BMI was 22, so which was considered normal. Blood pressure is 138/77. Her heart rate is normal, and her respiratory rate is normal as well. For her labs, her AST is 37, ALT is 43. Again, you will see that ALT predominance as you see with MASLD. 2 years prior, she had had an elevation in her ALT to 74, and this was 2 years before we saw her, and an AST of 63. But she had had fluctuating elevations since 2012. She would have times when they would go up, come back, normalize, which was up and down, and I think eventually she was referred to the hepatologist. Her alkaline phosphatase is 93, bilirubin is 0.5, A1C is 5.9%, and which puts her in a pre-diabetic category, and her cholesterol is 228, which is elevated, HDL is 67, which is protective for her, but her LDL is high as well. What are the next steps? So for this lady, we sent complete chronic liver disease workup. And again, it's because we can see that her BMI was 22. So when we saw her in the clinic, we definitely wanted to rule out every other cause of liver disease. Her Hep A was, IgG was positive, so she's immune to Hep A. She was immune to Hep B, and Hep C was negative. So her ferritin was 125. TSAT was elevated, but given the fact that her ferritin was 125, we didn't think that this was hemochromatosis. And you need to have a ferritin in women, I believe, above 400, and in men above 500 to be considered for hemochromatosis, and your TSAT is usually above 45%. Her alpha-1 antitrypsin, ceruloplasmine, ASMA, AMA, and ANA were all negative, so those were all ruled out. And we also checked the PEth, although she told us she wasn't drinking. We wanted to, again, to rule that out given the fact that her BMI was normal. And we did not believe that she had drug-induced liver injury. None of the medications that she was on would cause any drug-induced liver injury. So we went ahead and we put on checked an ultrasound, and the ultrasound showed a mild diffuse increase in echo texture compatible with hepatic steatosis. Checked the FIB-4 score, and her FIB-4 score actually was high, so it correlated with her ultrasound. And again, that goes back to what I talked about previously. In our first case, our patient was 33. And again, like I mentioned, FIB-4 is not the most accurate test for patients that are less than 40. It might be better for patients above 40. So this lady is 65, and the FIB-4 was on the borderline higher range. So the transient elastography was then done. She didn't have any fibrosis. Her F score was 0, but she did have a lot of fat in her liver with an S3 score. So let's talk about her risk profile. This lady has some metabolic risk factors. She has hypertension, she has hyperlipidemia, she has prediabetes as well. She is protected by the fact that she does have BMI and she doesn't use any alcohol or have any viral hepatitis. And this brings us next to what we call the lean MASLD phenotype, which are patients that have metabolic dysfunction despite a normal BMI. She doesn't have any fibrosis of imaging. However, she has significant steatosis. But then I just wanted to mention that in this patient's cardiometabolic optimization is still crucial, even though they don't have any obesity. So this slide is a slide from BMJ that just like quickly looks at the management of lean MASLD versus MASLD with obesity. And the management is pretty much the same for both types of MASLD. However, the difference is in the amount of weight that you're recommending these patients to lose. So in patients with like overweight or obesity, our goal is to make them lose 7 to 10% because it's been shown to regress the fibrosis and help with a MASH. If you want to just reduce liver steatosis, you should be pushing for a 5%, greater than 5% reduction in weight. In patients with MASLD, you choose a lower threshold, again, because their weight is already normal and you don't want them to become underweight. So the goal weight in these patients to lose, you recommend is like 3 to 5%. For patients that have MASLD, you always recommend the same type of caloric restriction diet quality. You always recommend a Mediterranean diet. You always recommend that they avoid processed foods and preference for unprocessed foods. We also recommend the same amount of physical activity, greater than 150 minutes per week of moderate activity or 75 minutes per week of intensive activity. With patients that have lean MASLD, you definitely want to incorporate a lot of like resistance training or like recommend that they have resistance training because these patients tend to also have some sort of like sarcopenia. So if they have a lot of resistance training incorporated with the exercise, it helps them more. And then also you need to make sure that these patients are not smoking and they're not drinking any alcohol. And then like for the implementation of this management of this both groups, they both need multidisciplinary management. They both need like behavioral therapy when they meet the criteria for that. They also need like lifestyle evaluation during healthcare visits, and they need affordable interventions. And then if they both develop MASH cirrhosis, it's the management again is adapted to the severity of the disease and nutritional status. If they're sarcopenic or they have decompensated cirrhosis, make sure they have a high protein diet. If they're compensated cirrhosis and they have obesity, continue to push for weight loss and physical activity. So in this patient, we had an interdisciplinary team. First, again, the primary care provider is the patient, the one is managing most of the care. With this patient, they were managing the hyperlipidemia, the hypertension, the prediabetes. And again, don't forget, these patients, although their BMI is normal, they're still at high risk for cardiovascular disease. So we should also be assessing the ASCVD risk, or the primary care should be assessing the ASCVD risk when they see them in clinic. And then with the hepatologist, when the patient gets referred, and this patient, we did see her in our clinic, we should definitely be staging, and trying to assess exactly what stage her fibrosis is at, or if she even has any fibrosis. For this patient, she didn't have any fibrosis, just steatosis. So our goal was to make sure she does not develop any fibrosis and to help, regress the steatosis on the liver. And then with this patient, definitely needs to see a nutritionist as well. And the nutrition should be focusing on a high protein diet. And like we talked about, patient needs to have a lot of resistance training, and you want to push for moderate weight loss, not significant weight loss like the other patient. And in our case as well, she was already seeing a physical therapist because she had chronic knee pain. But you also want to look at the patient holistically. If a patient has other issues like chronic knee pain, you should not go ahead and recommending, 150 minutes of moderate activity or 75 minutes of rigorous activity without having a physical therapist clear them, because now they have knee pain, so they need a physical therapist to see them and create a safe, sustainable exercise plan. And then finally, behavioral health. I always say that that's important. Like you can just see them in a clinic and just give them some support on the adherence and lifestyle changes. So what is our management goals in this patient? Short term, definitely goal weight reduction if possible. For this patient, we targeted a weight loss of 3.3 to 5%, giving her normal weight. And then our goal was also to like optimize her blood pressure, her glucose, her lipids. And she was starting on a statin when we saw her in clinic. Interesting enough, she was not on a statin when she was seen by the PCP. When we saw her, we started her on a statin, and then definitely helped to establish a regular physical activity routine. And then long term, our goal long term was to prevent fibrosis development and reduce our hepatic steatosis, as well as lower cardiovascular risk. So for monitoring and follow-up, this patient, you can check a liver enzyme even more spaced out, like every 12 months should be fine to check liver enzymes. The A1C, lipid panel, and blood pressure can all be monitored by the primary care doctor. And then for her fibrosis assessment, given the fact that she didn't have any fibrosis when we saw her initially, she can get a transient elastography or FIB-4 testing every 2 to 3 years. And then definitely make sure like you track her weight, her diet, and her exercise milestones. But this type of patient, we actually, in our practice, we actually sent her back to her PCP after seeing her for a couple of visits because she didn't have any fibrosis. And we thought that, if we could manage her other comorbidities, that her steatosis would improve. So we give the recommendations to the PCP to follow. And in my last case, I know we're almost running out of time. I'll try to go through this as quickly as possible. He is Mr. LA, again, referred for elevated liver enzymes. This gentleman has class 3 obesity, BMI of 40, and he also had a medial meniscus tear and was undergoing physical therapy. He's never had any surgeries before, denies smoking or illicit drug use, but then he drinks 1 glass of wine, 1 can of beer, and 1 shot of hard liquor per day. He recently completed his PhD in psychology, and he said, "Doctor, I've been stressed and it has been making me, drink a lot more during the evenings." Denied any drug allergy, no non-drug allergies, and he was taking diclofenac PRN for knee pain. Like I mentioned, his BMI was 40, blood pressure was 126/85. His respiratory rate was stable and his heart rate was stable. For his lab test, again, he had that ALT predominance. ALT was 120, AST was 64. His alkaline phosphatase was 83, T-bili was 0.4, A1C was 5.3, his LDL was mildly elevated at 127, HDL was 435, which is a bit low, and cholesterol was 186. What were the next steps? So for this gentleman, I believe when we saw him, just given his entire profile, the obesity, and also like he had a lot of like belly fat, I think we had a very high clinical gestalt that he likely had MASLD. So our workup was more tailored to ruling out viral hepatitis. He didn't get any autoimmune workup and stuff. So he got hepatitis panel, which showed that he was immune to Hep A. His Hep B was also immune. And then again, this was another patient that had a discordance between his FIB-4 score and his ultrasound. And his FIB-4 score was 0.56, while his ultrasound showed hepatomegaly and hepatic steatosis. And the transient elastography showed F3 fibrosis and an S3 steatosis. So what is the risk profile for this patient? He drinks 1 glass of wine, 1 shot of hard liquor, and 1 can of beer per day. This corresponds to at least 40 grams of alcohol or 4 units of alcohol per day. He does have significant hepatic fibrosis, advanced stage, and he has class 3 obesity. This slide is a slide just looking at the MET-ALD definition, and this is a slide from Gut and Liver. So I just wanted to briefly review this. I know we've talked about this in previous sessions, but I wanted us to look at the liquors that we have here and see exactly where our patient falls. So when you have obesity, body mass index above 25, or other cardiometabolic risk factors, you're already concerned about some metabolic issue going on in the liver. when do you call it purely MASLD versus MASLD plus alcohol? And the next slide is clearer than this, but I just wanted to show exactly where this patient is. He takes 1 glass of wine per day, which corresponds to at least like 2 units or 20 grams. He's also taking 1 bottle of beer, which puts him at like 10 grams in 1 unit. So that's 20 plus 10, I don't know, 30 grams, and takes 1 shot per day as well, which is corresponds to 10 grams. We'll go to the next slide. So this is this is another diagram from BMJ. And again, like we talked about, if a patient has more than one cardiometabolic risk factor and they've had current or past alcohol intake, if they're taking more than 20 to 50 grams per day and they also have evidence of metabolic disease, you're putting them at MetALD. They're not purely MASLD and they're not purely alcohol-related disease. Now, if they have more than 50 grams per day in women, then yes, that's alcohol-related liver disease, and you cannot call that MetALD. If the patient, as a man, is within 30 to 60 grams per day, he also has metabolic associated liver disease, and metabolic and alcohol-related liver disease. However, if he has more than 60 grams per day, then he's purely alcohol-related disease. So our patient, given the amount of alcohol he was taking per day, it put him in my calculation at 40 grams per day. So he was diagnosed as someone that had MetALD. So again, how do we manage this patient's interdisciplinary with the interdisciplinary team? So again, primary care providers are very important in this patient. And given the fact that he has obesity, you need to be screening him for multiple comorbidities. So you need to screen him for sleep apnea, kidney disease. You can always check creatinine at every visit, make sure it's stable. He also needs to be screened for thyroid dysfunction, screened for hyperlipidemia, because our patient actually only had obesity. He hadn't developed diabetes or hypertension. So he needs to be screened for hyperlipidemia, hypertension, diabetes, given his severe obesity. In this patient too, you need to make sure he's up to date on all his vaccinations. And the primary care as well helps with, prescription of anti-obesity medications. Because he doesn't have diabetes, I don't see that referring him to an endocrinologist for prescription of GLP-1 would be as important in this case. So you might have to talk about that medication with the primary care. So for the hepatologist, this patient definitely needs to be following us because they have F3 fibrosis, which is pretty severe fibrosis. F4 is when you have cirrhosis. So he does have F3 fibrosis. So we need to monitor him for disease, make sure the fibrosis doesn't progress. And if he develops F4 fibrosis and decompensation, we need to see a transplant hepatologist. A lot of times we should be managing patients that have compensated cirrhosis. And then we need to screen for I'm sorry about that. I think we just got a message. Okay. Should I keep going?
Yes, you can finish that.
Okay. Definitely a nutritionist needs to see this patient. And for this patient, we were targeting a 10% weight loss. So the nutritionist needs to offer, caloric deficits, its portion control, Mediterranean diet, a plate diagram. The nutritionist would need to definitely help with losing weight in this patient. And then we also had a physical therapist following the patient because he did have a meniscus injury. And again, we can't just recommend rigorous activity without him seeing a physical therapist to carve out a safe, progressive physical activity. And this patient should also be seeing a behavioral health or a psychologist, just given the fact that some studies have shown that patients that have obesity have increased risk of depression. So you need to screen for depression, also assess for emotional eating, and help manage any social and occupational challenges to adherence. And I'll definitely refer this patient to a bariatric surgeon given his BMI of 40. So for his medical and pharmacological management, in this patient, the mainstay of management was weight loss. We actually started him on a GLP-1 agonist with the help of his primary care physician for a goal weight loss of 10%. And he also referred him to a bariatric surgeon. A lot of times I'm seeing now, the bariatric surgeons are saying, let's try out the GLP-1 agonist and see how they do in a couple months. And if they lose appropriate weight, then we don't need to make them go through surgery because Dr. Meza mentioned, bariatric surgery has its own complications, So we're still putting a referral to see the bariatric surgeons. And then there are other medications. It's like vitamin E has recently been, shown to have good outcomes in this patient. And so you can always consider that medication, but I just wanted to mention that there's some side effects that have been associated with these medications, and it includes overall increase in mortality. There's increased risk of hemorrhagic stroke and even prostate cancer in some patients on vitamin E. And then this patient, because he has that ALD, he definitely needs to stay away from any alcohol. He cannot be drinking any alcohol. So we need to counsel him extensively, and the behavioral health will also help with counseling. And then the other question is like resmetirom, if the patient should be on it. And like I mentioned earlier, there's just insufficient evidence on if we should be putting a patient on resmetirom while they're on a GLP-1 agonist. So for this patient, I would definitely monitor him closer. So for liver, I recommend doing a liver panel sooner, every 3 to 6 months, given the fact that he had F3 fibrosis. He should be getting a transient elastography every year. And I would use a transient elastography and not a FIB-4 score again, because he had that discordance in the beginning where the FIB-4 score was basically normal, but his transient elastography showed significant fibrosis. Then for his cardiometabolic panels, he needs to get A1C and lipid panel monitored because he's at increased risk of developing this condition. So it needs to be monitored by the PCP. And also for this patient, he has F3 fibrosis. So we'll actually need an ultrasound every 6 months because he has advanced fibrosis. So some patients, a small set of patients with F3 fibrosis can actually go ahead to develop HCC. So you also want to be screening this patient. If he ends up, if his fibrosis on future transient elastography ends up decreasing from F3 to maybe F2 or F1, then we don't need to do the ultrasound every 6 months. You can always refer the patient back to a PCP if his fibrosis improves to F0 and F1. So quickly, what are the take-home points with these cases that I mentioned today? Just like Dr. Meza talked about, it's very common in patients that have metabolic comorbidities and carries risk of progression to fibrosis and cirrhosis and major cardiovascular disease. It's very important to detect fibrosis early. The cornerstone of management is lifestyle intervention, diet, exercise, weight loss. And given the comorbidities associated with this MASLD and fibrosis, it's important to have an interdisciplinary team follow as soon as possible. And then make sure you also set realistic, measurable goals in your patients and monitor progress. And patient education, adherence, support, and coordinated care are vital for successful outcomes. And I think that's it. Thank you. We have any questions?
Yeah, I'm gonna go ahead and share my screen again for the last few slides. Yeah, if anybody has any questions, feel free to drop them in the chat, and Dr. Asotibe and Dr. Meza can answer them, or you can unmute and just ask the question. I don't see. I don't see any questions in the chat. I'll give it one more minute, and if there's no questions, I'll just stick around after for a little bit. Okay, I don't see any questions, so I'm just going to move on to the next slide. Okay, as a reminder, mark your calendars for the last Project Echo session, December 2nd, 2025. I've also included a QR code you can scan to register if you're not already registered. Please make sure to do the survey at the end of the session, as it will help us improve future sessions. So there's that QR code at the end. Yeah. And also, finally, a heartfelt thank you to our program sponsor, 89 Bio, for sponsoring the 2025 Project Echo sessions. This concludes our third session, and our next session will be Tuesday, December 2nd, covering MASLD early detection and management at 12 p.m. Eastern Time. Thank you, everyone.